You're tuned into Recovery TV, the voice of hope, with your host, John J. Tassoni Jr. Discussions and information on addiction and mental health issues. Here's your host, John J. Tassoni Jr., with today's guest.
Welcome to another edition of Recovery TV, and I'm your host, John Tassoni. Narcan, please get it, and get it at CVS, any pharmacy, URI, put it in your purse, keep it in your car, take it out at night because the weather affects it. My two guests today you're lucky, I have two. Wendy Looker of SUMLC, which is the Substance Use Mental Health Leadership Council of Rhode Island, and Lisa Peterson from Victor. And today, ladies, we're going to talk about what you do with the health homes. What is a health home?
So a health home, that began in 2013. And it was put into place for Medicaid recipients in Rhode Island who were enrolled in an OTP, an opioid treatment provider. And what it did was expand services to include things such as case management, to increase coordination and collaboration of care, to help them navigate the difficult social services that are needed, to ensure that they have dental care, to ensure that they have a primary care doctor, to help with discharge if they've been admitted into a hospital. So it's been around for 12 years, and Victor is one of the OTPs who provides that service. And I think it's really been a huge help for those people who need it.
Does it save money?
Oh, absolutely, it saves money. It saves so much money because this is a really complex population. They have a lot of co-occurring social needs, healthcare needs, and they have a lot of barriers to accessing those. So just to be able to meet with a nurse, a case manager, to help them navigate this really complicated system of healthcare we've created really helps avoid things like unnecessary emergency room visits, hospitalizations. It keeps them healthier overall, which is both right for the people we serve and right for the Medicaid budget.
So take me through an individual who comes to Victor that wants to have your services rendered to them as a health home person. What do they have to do?
They just have to say, hi, I'd like health home services, please. They do need to be on methadone treatment for their opioid use disorder, and they just have to tell us what's going on with them that puts them at risk that we can help out with. So whether that's one example that comes to mind is a co-occurring diabetes diagnosis, and they're not taking very good care of themselves because they're in active addiction. We can't just stabilize the opioid use disorder.
Yeah, it's
absolutely,
the whole
absolutely. Yeah. So we can help them figure out how to maximize those services as well. Like they might think, hey, can you help me get on my food stamps reinstated. And yes, and in addition to that, we can sit with you while you try to find a primary care provider in this environment.
So it's almost like a one-stop shop.
Mm-hmm.
Yes.
How did the state come about doing this OTP?
So back in 2011, we started working on this initiative and working toward a state plan amendment, which would allow us to provide these services. The reason behind it is when people are involved with OTPs, they're seen almost daily, or daily at least to begin with. So what better place to be able to get someone to coordinate services? Oftentimes people think health homes, we provide help within the home, but that's not what it is. So for that reason, it began in methadone clinics. I don't know if it's evolved in any other state to other forms of treatment, but in Rhode Island right now, it's just in methadone.
This is probably one of the most best kept secrets.
Absolutely. I think that people think of methadone clinics and they have a very narrow view of what that means for the person who's receiving services. They go, they take their medications, they walk away. But our nurses and our clinicians and case managers have so many contacts because they are coming in so frequently. It's an opportunity to develop a trusting relationship so that when we say, hey, we're really concerned about this health condition, if we make a referral, that's going to be a lot smoother than handing someone a card with a phone number, call this person blindly, maybe you get treated well, maybe you don't because of your addiction. So we're able to really bridge those gaps.
So what if someone comes in and says, Lisa, I want to join a health home. I have chronic health issues, I have heart issues, I have diabetes, I got a number of different things. So you're telling me that John would come in and meet with you, go through a scenario, meet with the doc or the nurse, and then be passed on to another individual, but I would be able to come back tomorrow and see how I did overnight and take my medicine, and then come back on Wednesday. So it's almost like I don't want to use the word revolving door, but it's almost like you have access rather than go to the emergency room where you're going to be there for 8, 9, 10 hours.
Yeah, we really try to help set realistic, immediate, short-term goals. People come in with long-term goals. I want to feel better. I want to be all healthy. That's great. Let's start with, did you keep your appointment with your cardiologist?
Right.
And if you did, let's get those records. Let's make sure we're all on the same page. Let's coordinate with the nurse or the medical team that you're seeing outside of here so that we're not doing anything here that's contraindicated for them and vice versa.
You know, it amazes me because when you go to your regular doc, and no one is actually talking to one another, you know, and then you have a place like a health home where it's all inclusive and someone is talking in and out of the place that you're at.
I think for far too long, OTPs operated in a silo. I began working in this field in 1994.
Really?
Yes.
1994. Let me do the math.
I'm 29. And in that time, we never even talked to the doctor. We didn't have them sign releases because we didn't want people to not have access to care once the doctor found out that they were on methadone.
Yeah.
Things have moved in a much better direction, and most doctors are much more accepting of it now. So it really has been a lifesaver. So, you know, just to expand a little bit on what Lisa said before, if you walk through the door and you were a Medicaid recipient and you were on methadone and you said, Lisa, you know, I'd really like to be part of your health home, we'd go through a few different little assessments, and then she would work with you and say, okay, John, what do you want to work on? What do you feel is the most important thing? Even if we don't feel it's the most important.
Yeah,
if it's the most
patient.
important for you,
Right.
that's where we're going to start. And so she'd come up with a nice little plan of care, and you'd get a copy if you wanted it, and you and your case manager would work on that goal. Check in as often as you'd like, but you know, you also have other people on your team, not just your case manager. There's a health home RN, there's the health home doctor, there's a hospital liaison, there's a pharmacist that will review your current prescriptions and see if any of them interact with methadone, how they would interact, and make sure that everything is being done safely for you.
How long can you stay in a health home?
As long as you need to. We're constantly reevaluating. People's needs change, people's goals change. They might achieve some of the most emergency needs that they identified when they first came in, and then down the road they might say, hey, you know, I have this itch and I need to see a specialist. Can you help me find that? So we're always reevaluating the needs and encouraging people to use us as a resource and to advocate for them.
How do you get your clients?
Well,
Is it just word of mouth?
No, they're already part of the OTP.
Right. But if you let me put it this way. If I was to go to Kennedy Plaza, there's a lot of folks over there that use. And I want to talk about this when we come back because I got to go to break. Are you able to go there with a flyer and say, hey, maybe you should check out the health home? I want to talk about that when we come back. You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back after these messages.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Wendy Looker to my right, Lisa Peterson to my left. Lisa's with Victor, and Wendy's with the Leadership Council, talking about health homes and the OTPs. Ladies, thank you for joining us, and thank you for what you do.
We're happy to be here.
I think that if health homes didn't exist, we'd be in a much worse position than we are today. But I want to talk to you about outreach. What are we doing for outreach? I mean, as I indicated at the last part of the segment, you know, Kennedy Plaza, there's a lot of folks down there that need help. Mm-hmm. You know, is there brochures being handed out? What's being done?
We have a lot of really strong relationships with organizations who have a presence at Kennedy Plaza and in some of the encampments and places that people who really could benefit from treatment, but are not accessing it for any number of reasons, logistical priorities, things like that. So a lot of it comes from community relationships and that trust that you build with people, that if they make a referral, that yes, I believe that this person will treat me well and take care of me and listen to my needs, as you said earlier. So a lot of it is that kind of relationship building in the community, and less so, you know, a flyer can be looked at, thrown away, but when you see the same person doing outreach and you say, today's the day, I think I want to get treatment, you trust that person to make a good referral, and that's what the treatment providers are there for.
What about transportation? Transportation is a huge issue, whether it be buses, MTM, or any of the others, Uber, Lyft. What about transportation?
So that's something we can help people get set up because of the health homes. So we can help them with their MTM application or the bus passes that they're eligible for. There's so much that people are eligible for with Medicaid benefits that they don't know about. So we can provide that education. And again, when we're identifying one of the barriers is transportation, great, that's our very next goal then. Let's work on a solution to that. So we leverage the bus passes and MTM quite a bit. And then in a pinch, when needed, we will absolutely send somebody a Lyft or an Uber to make sure that they get to their appointment with us or to their appointment with a specialist to follow up, so that we don't just, again, hand them a piece of paper and say, good luck, hope you make your appointment.
Yeah. Let me what's your biggest obstacle with the health homes?
Well, I think it's not just with the health homes. I think overall, a huge obstacle right now is the workforce. I think it's challenging sometimes to have a full complement of employees, and I think that the OTPs, all the employees that they do have, work extremely hard, you know, to make the program work. But our workforce is dwindling.
You know, it's not funny, but it's complicated. You know, since COVID, where did all these people go? You know, the healthcare sector has been decimated. Nurses, doctors.
Well, if I can be so bold.
Yes, you may.
Thank you. I think it's very sad that we have people that, and it's not to knock anything or disparage anyone, but if you were someone who could work at Target, check people out, and go home at the end of the day and not have to worry about anything other than checking people out, or if you were somebody who had great responsibility for, you know, trying to assist people in not only treatment, but also in, you know, their health home needs, for the same amount of pay, where are you going to go? So did we maybe lose some people, you know, from the healthcare end into retail and
well, I think that's one of the things that the rate review did. Has helped out tremendously, and it's not going to come back overnight. It's going to take a while. I think the schools need to be on board. The workforce with the state needs to be on board. The nursing middle college needs to be on board. I think we all have to strive for the same goal, that we don't find ourselves in this predicament again.
Well, the good thing is that most of the agencies that I've talked to people, or at least a lot of the agencies that I've talked to or worked with, they do take interns. So I think it's very beneficial to establish the relationships with, you know, the nursing schools and the social worker programs and things like that for future workforce needs.
Well, the other thing is too, it's good to have interns, because if the intern doesn't like that sector, it can go on to another sector, i.e. what I did with my daughter when she was a senior in high school. She wanted to be a physical therapist, so I knew a physical therapy place. I said, hey, you're going to go to work over there after school. And after about 2 weeks, she said, Dad, I don't want to do that. I want to do something else.
Sure.
So what is she doing now? She's in a different area of business. But my point is, every child should try what they think they may like, instead of spending hundreds of thousands of dollars now in college education, and you come out and you don't like what you do. That's not good. I mean, I sat on the Nursing Shortage Commission back in 2006, 2004, and we knew in 2020, in 2025, we were going to be 5,000 nurses short, and it's happened. And it's happened. The amount of stress and the amount of hours being worked by nurses now, it's beyond belief. It's beyond belief. So we have to all try to row in the same direction and try to make sure that, you know, we have nurses, we have PAs, we have substance use and mental health folks, we have psychiatrists. We need to work on psychiatry. Well, you know, my last guest was talking about, you know, the shortage of psychiatry. I mean, kids today, it's almost 12 months before you can see a psychiatrist. That is not good.
It's criminal.
Is it still 4 to 6 for an adult to get an appointment, or is it more now?
Not at Victa, certainly. But yeah, I think in the general outpatient space, it's really difficult to find a provider. And it's really difficult to find a provider who's going to take insurance.
Exactly, 100%.
Because they've opted out because of all the bureaucracy and the low rates, and it's just not worth it. But I think the value of the health home program to employee retention, to staff, to the workforce shortage is, nurses, case managers, they want to go above and beyond. It's who they are. And the health home allows them to do that, where in your traditional outpatient model, you've just got to see the person who's in front of you and hope for the best in between.
You got 10 minutes.
Exactly,
You got 10 minutes
if you're
to
lucky.
Get them out.
Yes.
All right, well, I got to take a break. You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back after these messages.
Now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Lisa Peterson and Wendy Luca are my guests today. Wendy is with the Leadership Council, and Lisa is with Victa. Thank you, ladies, for coming on. I greatly appreciate it, because I think this is a very important issue. Best kept secret in the state. Wendy, what's your thoughts?
Well, health homes and OTPs, they are both the best kept secret. They both will save tons of money by keeping people healthier than if they were out on the streets and still using drugs. And you know, one thing we should touch upon a little bit is harm reduction. For many people, that's a taboo type thing. But my feeling is, if we keep people alive, they always have the chance to choose treatment and recovery.
Well, Lisa, you have 40 seconds to tell me about harm reduction.
About my passion for many, many years. So over the course of the last 6 years, I was fortunate to work with a coalition that got legislation passed to open the first state-sanctioned safe consumption site or overdose prevention center. And that is embedded within a larger harm reduction organization in which Victa and Project Weber Renew have partnered to provide a range of services. So since our opening of that second site at 45 Willard Ave in January, Victa has had a minimum of 90 unique individuals seek either a medical or a clinical service, and 71% of those folks have kept some kind of follow-up after that, which
We're
is
going to
unheard of.
have you come back because we're out of time.
That's amazing.
You've been watching Recovery TV, and I'm your host, John Tassoni. MAP, which is a residential treatment facility, will be my guest next week. If you see something, say something. See you next week.